time where you didn't have that, like, you're on a track, you're going through, you're just like liking.
Yeah.
I'm gonna ask one of them to moderate the chat.
Okay.
You want me to-
I was temporary and it was super nice too, but back then, like all the leaves was like so green. So I imagine when you went now, it was beautiful.
It was getting there. There was still some like, there was still some green, like you probably would have a little bit more Vermont.
Gotcha. That's awesome.
I don't know, I've got like a. My mom's in New Hampshire right now, and it's not like.
No, you're. I remember.
I
What's up?
think we'll let you eat.
Huh?
Do you want to eat first?
I'm fine.
Okay.
I'll eat after.
Yeah, I was.
Yeah, it's okay.
I was mentioning earlier with my uncle, he lives like right across from Dan and Witt's. Like in Dan and Witt's. It's in Norwich.
Oh,
I've never went over to Norwich.
I went to Woodstock. I haven't bounced around. My old PI used to live in Norwich, and then I guess I'm you like the.
All right, guys, we are gonna get started. We have Dr. Jason Yang here with us tonight. He is a resident at RWJMS, and he'll be talking to us about basic orthopedic principles and also some x-rays and stuff, and really helping us out. So thank you for coming.
No problem.
And
Yeah, sure.
What's up? I'm Jason. I'm a third-year resident at Robert Wood right now. I actually went here for med school too, so I remember being in your shoes not that long ago. So you guys are 2s and 1s and undergrads mostly. You guys divided like by table. That's cute. You guys are all the undergrads? Okay. You guys are all you guys are 2s. Okay. All right. Cool. Yeah. So like ortho is like a very exciting and expanding field. A lot of people are getting interested in it. It seems like every year there's more and more applicants. So that's great. In my opinion, it really is the coolest field in medicine. You know, my colleagues are the hardest workers I know. They're really smart. They're really talented. And we get to do a lot of really rewarding work. The surgery itself is really cool. The patients generally have great outcomes. So, you know, I love it. It takes a lot of sacrifice and hard work, but I think it's worth it. So thanks for being here and being interested. So let's talk about some fracture stuff, some x-ray basics, and then, you know, I'll try to keep it short because I know you guys all have things to do or places to be. So I'll kind of breeze through the slides, but I'll kind of open it up to like a Q&A. So if you guys have general questions about like residency or, you know, transitioning from med school to residency, anything like that, like I'll just field that kind of stuff because I feel like that'll be more useful to you guys. Cool. All right. Any burning questions or anything first before I get started? Just like anything anybody's wondering? No. All right. Cool. Okay, so reading an x-ray, basically, you know, the 2s have taken anatomy and the 1s have not. Oh, yeah, everyone, oh, that's right, everyone has, you guys have it. All right, so basically when you're looking at an x-ray, it's kind of intimidating because there's a lot of bones and you don't know what's going on. So just to break it down, if you do it the same way every single time, it'll be easier. And then even on your boards, you know, they'll ask you like, hey, what are you looking at? Like, and you have to break it down like, okay, I'm looking at this, this, and this. So always start with the view of the x-ray you have, right? So this is 3 views of a hand, right? And this is an AP view, which is basically like a straight on, face on view, an oblique view, which is oblique, and then a lateral, which is the side view, right? And whenever you're looking at x-rays, one x-ray is never enough. Sometimes you can have an x-ray that looks perfect on an AP view, but then you look at the lateral and it's completely like bent over. So always make sure you have all the appropriate views that you need. There's also a bunch of special views, for example, like a scaphoid fracture. Sometimes those can be really hard to see. The scaphoid is this bone right here for those people who haven't taken anatomy. Those are like, you know, pretty infamous fractures because they can actually go into non-unions, which is basically when they don't heal properly and cause chronic pain. So they can be easily missed. And sometimes it's important to get something like a scaphoid view where you basically like turn the hand out this way. So just knowing your basic types of x-rays that you can get can help you out a lot. So again, starting here, this is an AP oblique and lateral, then you say the body part. So is it the pelvis? Is it the shoulder? Obviously, this is the hand. So, you know, when you're asked to read an X-ray, you're gonna say there's an AP, oblique, and lateral view of the right hand. All right. Then you want to look at, are they skeletally mature or immature, which basically means, are they a kid or are they an adult? You know, when you're first starting out reading X-rays, a growth plate or a physis can look a lot like a fracture. So, you know, when I first starting out, I was like, oh my God, everything's fractured in this kid, but it's just a child. So, all right. Also, it's important because if you don't address the growth plate, you know, all the subspecialties within orthopedics, pediatrics is its own whole subspecialty, and that encompasses how to manage growth plates and growth. So if you have a fracture through a growth plate, you have to think about, like, is this person going to have a growth arrest? You know, if you have one part of your bone that stops growing as opposed to the other side, you can get angular deformities. You can get one limb being shorter than the other. So there's a lot of things to consider when you're talking about growth plates. So just something to mention, if you're looking at a fracture, think to yourself, are they a skeletally mature adult or are they a child? And that kind of changes your management. Also, pediatric bones are a lot more malleable. They're not as brittle. So they get kind of different types of fractures sometimes, and they have a lot more ability to mold and come back to their normal shape. It's called remodeling. So basically, if you have like a really bad fracture in a kid, you can just kind of push it back and splint it, and a lot of them do fine. Whereas an adult, it would absolutely need surgery. So these are all like little considerations to take into account. And then you get into the fracture description. So you're looking at the fracture. How do you describe the fracture, right? And this is important because let's say you're the resident on call overnight and, you know, a bad fracture comes in and you're talking to your attending and it's 2 a.m. and they're tired and they're upset that you woke them up, but it's for a good reason because this person has this type of fracture. Well, I don't have my X-rays up in front of me, describe it to me. So you can describe to them what you're seeing on the X-ray, and that'll tell them, okay, is this someone I have to go into the middle of the night to fix? Is it somebody that I have to do surgery on tomorrow, or is it someone I can send out and see them in the office, right? So your ability to describe the fracture not only helps you as a resident, but then as an attending, you know, how are you going to fix this fracture? How are you going to treat it? It all depends on the type of fracture, who it's in, and yada, yada, yada. All right, so when you're describing your fracture, you can think about the pattern, the fracture pattern, the location, like what body part it's in, what bone it's in, and the deformity. So what results as the fracture? What do you see that's abnormal, and what do you need to fix? So there's different types of fracture patterns. There's complete versus incomplete. You know, it's really funny. Like a lot of patients always ask me, like, "Oh, is it fractured or is it broken?" Like, so many patients ask me that. And it's just general knowledge, apparently, that a fracture is different from a break. No, a fracture is a broken bone, and it can be either complete or incomplete. So a complete fracture is basically through and through both cortices. Incomplete fracture is like I was talking about in kids earlier, where it's only kind of one cortex and it's kind of bent more than is actually fractured, but it's still a type of fracture. All right, so let's go through the different types of patterns. You have transverse, oblique, spiral, comminuted, avulsion. These are all just adjectives you can use to describe the fracture pattern. Okay, so I'll let you guys look at that for a second. So as you can guess, you have a transverse fracture, which is kind of straight across the bone. You can have an oblique fracture, which kind of comes in at an angle. You can have a spiral fracture, which has a rotational component and usually is associated with some sort of twisting injury. And that kind of goes up. And then you can have comminuted fractures where you have multiple pieces that are kind of shattered in small shards. You can have avulsion fractures, which are basically, you know, a strong ligament that attaches to where that bone is and pulls the bone off. So why is this important, right? So let's say you have a transverse fracture. Typically with bone, you want a certain degree of compression for it to heal, right? If your bones are like this and they're this far away, it's not really going to heal very well. So if you get bones to come together in the right way, in the right alignment, give it some compression, you have a better chance of healing. So oftentimes we'll see tibia fractures, for example, like in a kid, your tibia, you guys know what a tibia is? You sure? You know what a tibula is? You know what a fibula is? All right, just all right. So basically, if you have a transverse fracture of a tibia, I actually saw this recently where it was a kid and we put them into a long leg walking cast. So basically, we put a cast on them with them, put weight on it, because it's transverse, the bones just will compress on each other while they're walking. If it was oblique, right, they would shear and displace if you put weight on it, right? So important considerations. Also, like if you're gonna fix something, if you're gonna fix a transverse fracture, you can provide compression this way. There's multiple different ways to do it. If it's like a weight-bearing bone, like I said earlier, you could do like an intramedullary rod where you can immediately weight bear and let the bones kind of compress each other. If it's in a bone like, you know, your radius or your ulna, you can do what's called compression plating, which is basically like if your fracture is like this and your bone is like this and here, you could put a plate across here and a screw in here that serves as your post. You put that screw in and that's not going to move. You put the screw in on this side in an oblong hole, and basically the screw head, as it goes down, pushes the plate this way. Does that make sense? So your hole is kind of like, think of it like a triangle in a way, and your screw head goes down, and as it slides down, the plate moves out that way. Am I explaining that decently? So that way you can cause compression of the bone fragments together with the plate. But you can only really do that with certain types of fracture patterns. Or if you're going to do it with an oblique fracture pattern, you have to think about it a little differently and adjust your screws accordingly. All right. Let's see. Comminuted fractures. So basically, like it means like 3 or more pieces. If you have a comminuted fracture in a femur, it's pretty amazing. You can just, you know, still put a nail through it, and as long as you have good alignment and length and rotation, you're going to do fine most of the time. You can walk on it. You can put weight on directly onto the nail. You don't have to fix every little fragment. In like, let's say a distal radius or like an ankle, you can't really do that because it's the articular surface. So you're going to have trauma. You're going to have a post-traumatic arthritis in a lot of cases if you don't address the comminuted pieces and get the cartilage back together. So that's kind of, you know, important to consider. And then avulsion fractures, you know, most of the time it depends on how displaced they are. You know, we talk about like if you tear something, if you tear a ligament, right, you're probably not going to have an avulsion fracture. But if you have an avulsion fracture, your ligament's likely intact, but the bone is kind of pulled away. So it depends on where it failed first. You know, this comes into play with, let's say, like a proximal humerus fracture, right? A humerus is your bone here, and then your proximal humerus is basically the bone that articulates with your shoulder, and then your rotator cuff kind of drapes across and attaches right onto the tuberosity of your humerus, right? So oftentimes if you get like a greater tuberosity fracture, which is big piece of bone sticking out here that your rotator cuff attaches to, they can pull it off, and then now you can't really move your arm as well, and it actually might pull the bone back into the joint and it impinge, so you can't use it anymore. So recognizing that you're having some sort of bony avulsion from a ligament or a tendon is important because they'll kind of help you keep those things into consideration. Is this way too much? Like, are you guys good? Makes sense? All right, cool. So this is like, just, you know, this is kind of more advanced, but just something that I found that was cool is like understanding how the physics work. You're basically manipulating the physics of these forces in the bone to do what you want it to do. So a lot of hip fractures, we treat based on blood supply. So a femoral neck fracture, which is this part of the bone here, we treat differently than intertrochanteric fracture, which is kind of here. These are the trochanters. Fracture here versus a fracture here is very different. The reason for that is that there's a joint capsule around every joint, right? So you have fibrous capsule around this joint here, and the capsule includes the femoral neck, right? So if you try to fix that, if it's really displaced, it won't heal very well because there's no good blood supply into the capsule, right? Whereas opposed to out here, you have good blood supply, so you can just kind of get the fractures, the bone realigned, and it'll heal. So this here, so does anyone know the major blood supply to the femoral head, the femoral neck? Yeah, this motherfucker, right? MFCA, yeah, never forget that. All right, so.
Hurry before our last exam.
Yeah. Was there a question?
Yeah.
Good, good. Who got it wrong? Good, yeah, never forget. But basically, you know, If it's really non-displaced, you could do something called cannulated screws, which is basically just 3 screws that go straight into the head. But, you know, if they are displaced, which, you know, can happen more frequently, if your femoral neck is displaced, we usually have to treat that with a hemiarthroplasty or a total hip, right? We basically replace the whole joint like a hip replacement because of the blood supply, because it's not going to heal. And then, you know, there's a whole conversation about hemi versus total. And that's another reason why I like orthopedics, because it's not just like, okay, you have this problem, this is how you fix it. Like, you have to take into account like how old they are, like who they are, what they do, their functional status, what are their goals, right? So like, you don't just say you have this fracture, let me do this. Like, well, no, like, are you active? Do you ride like a bike 10 times a week? Or do you sit on your couch and do absolutely nothing because you're 90 years old? Like, that's, you know, it's, you treat them differently. And, you know, all these different treatments have different functional outcomes. So yeah. But basically my point with this is that, let's say, for example, you treat somebody with cannulated screws up into the head and they go on to what's called a non-union, which is basically where it doesn't heal the way you want it to. One of the reasons for that is that this is like a pretty vertical fracture. And as you walk on it, you can imagine that this causes a shearing force down this way. So if that happens, something you can do is what's called a valgus osteotomy, where you basically cut out a wedge with a saw of the femur and you bring this whole thing down. And now your fracture that was shearing is causing compression when you walk on it. All right. I think it's pretty cool. You're just, you know, you're manipulating physics and the bones to help you and the patient. So, you know, there's other instances like that all over, like with kids, you know, pediatric patients who have like chronically dislocated hips, you know, or something's wrong with their muscular imbalance, or something's wrong with, you know, their spine or their pelvic anatomy, whatever. There's a lot of different reasons kids can just have like hips that are dislocated. Something you can do is called like a VDRO, is a valgus producing osteotomy, basically, where you do the same thing. Like, you take the femur and you literally make it more like this, so it stays in the hip joint, right? Like, wild. I don't know. Crazy. I think it's pretty cool that we came up with that. So these are just incomplete types of fractures. There's a green stick fracture, which is literally like, you know, one of those green sticks you find outside and you try and push on it, like it just snaps on one side. That's a green stick fracture. These happen in kids mostly because, like I said, they have more malleable bone. They're not as brittle. They're not going to snap, right? The torus fracture, which is kind of similar, where it's kind of like you're crushing a can and it just kind of pooches out. That's kind of your torus fracture, or buckle fracture is how they call it, because apparently it looks like belt buckle. And these, you know, are generally pretty benign. Like, it's a stable fracture. The cortex is usually intact on the other side, and you can just treat these non-operatively most of the time. So location, we talked about, you know, it's important to know, like, is it proximal? Is it distal? Is it mid shaft? Because these change how you're going to manage it. These change how close attention you have to pay to it. So again, this is the tibia, right? And this is what is this? This is an AP view of a right knee, right? And you're looking at the tibia here, and you can see there's a little discontinuity of the fracture line, right? The little cortex. You everyone see that? There's a little fracture here. We call this a tibial plateau fracture. And that, like I said earlier, is part of the articular surface of the knee, right? So if you don't address this properly, your knee is going to put weight on this part of the, your femur is going to put weight on this part of the knee. You're going to have really bad arthritis eventually. You're going to have a lot of knee pain. You're going to feel unstable. You won't be able to walk on it. So these are all things that can happen if you don't address it properly. You know, this is a mid-shaft tibia fracture and also a fibula, which, as I said, in this patient would probably be treated with a nail, and you'd be able to walk on that. You don't have to get all these pieces perfectly aligned, because you can, you know, it's a weight-bearing bone. That's its only purpose, right? As opposed to the other bone, the other part of the bone, which is to articulate and give you motion. Okay. So that's how we fix them. All right, so this is the tibial plateau fracture that we treated with an ORIF, which is our orthopedic term that we say all the time: open reduction internal fixation. Basically make an incision, you go through the anatomy, try not to hurt anything, or, you know, bag the scary structures, and then you fix the bones by literally, you know, whatever means necessary, with clamps and tamps and whatever you need to get the bones realigned. And then you put a plate on the side. This is a specially designed plate for this specific bone and this specific part of the bone, like a tibial plateau plate. And then you put some screws across. This screw is kind of going underneath the joint line, just serving as like a rafter, so that you know, the parts of the bone that you elevated back up don't collapse back down. And then, you know, that's pretty much the treatment for that. And then this is an intramedullary rod, like I was describing earlier. It's pretty cool. I mean, you just take somebody and you open up, you can go suprapatellar or infrapatellar, and you dissect down and you find the tibia and you just hammer a rod down their tibia. And you just put a few screws in to keep it stable and they can walk on it the next day. Like, yeah, you know, so yeah, so the location is important, you know, identifying where the fracture is kind of guides your management and how you're gonna treat the patient. Other things to note, like this person on the right with the tibial plateau fracture, they're not going to be weight bearing for like 6 to 8 weeks at least, right? So you're gonna tell them like, hey man, like, buddy, you're not doing anything for 6 to 8 weeks. Whereas this person, like, you know, they can walk down the hallway, you know, in 3 days, like, so. Deformity. So when you're describing your fracture, it's always describing the distal fragment in relation to the proximal fragment. Do you guys know what I mean by distal versus proximal? Okay, so distal being like further away from the core of your body, proximal being closer. So the distal fragment, if you break something, is how we describe the displacement or the angulation, the length, the rotation. So when you're talking about displacement, you're talking about kind of in the plane of like translation. Is it displaced or is it non-displaced? Length, you can have, for example, if your bone fracture is, you can have it kind of bayoneting like that, and then you get shortening. Angulation, your bones can kind of go like this or like this. Do you guys know like the difference between varus versus valgus? So valgus is basically like knock-kneed, and varus is like this, right? So you can imagine like if you're playing football and someone hits you from the side, that's like a valgus producing force. Varus is kind of like rarer, but I mean, I guess if you were hit from this way, that'd be like a varus force. So your fracture can be varus, valgus. It can be dorsal, which is back, and volar, which is forward. These are all important things to note. You can have rotation, internal rotation, external rotation of your fracture. So when you're trying to reduce your fracture, reduce is just a fancy way of saying put your bones back together straight. You have to keep these in consideration. So there's just a little graph or a little chart showing different types of deformities. So this is proximal, meaning this is like my femur like this, and lateral, medial, and distal. So this is distraction where you have pulling away of the bones from each other. You can have lateral displacement where it's kind of shifted laterally and translated. You can have complete lateral displacement where it's not even touching. Like here, you can imagine the cortices might have some sort of apposition, but here they're just like completely not touching at all. Here's some angulation. This is angulation and displacement, and this is like angulated, displaced, short. Like that's not great.
Can I ask a question?
Yeah.
What would be an example of the lengthening deformity?
Lengthening deformity. So you could have, like, for example, like let's say you get like a really bad segmental fracture and you have like a big bone defect, right? So like you have like bones like this that just like aren't touching each other. Or for example, like you get like a midshaft humerus fracture where like now gravity is pulling the distal fragment down and the proximal part's still up here, held by your deltoid muscles and your shoulder muscles. So now your fracture is kind of like this. So you look at the x-ray and it's like, oh, it's distracted. Like it's not really, close together. Or like, in surgery, when you're kind of trying to put bones back together, like something you can do is like, if they're kind of stuck like this, you distract them to get them back to length and you put it back together. But sometimes if you don't, come off with the distraction before you put it back together, it's going to stay distracted. And like you look at the x-ray, it's like, oh, that's distracted. That's not going to heal or something like that. Yeah. But yeah, so you're right. It's very uncommon to like have a fracture and be like, my bone's like further away from me now. Doesn't really happen. Summary. So other things to consider, like soft tissue involvement. So like we're bone doctors, but actually like the soft tissue is super important. Is it an open fracture versus a closed fracture? So does everyone know what an open fracture is? So an open fracture basically is when you have your bone exposed, it broke and the sharp edges broke through the skin and it's open. There's different classifications of how open it is. And it's largely based on the size of the opening and whether or not there's soft tissue damage to the nerves or the vessels. So bone doesn't heal without good soft tissue coverage. So we work very closely with plastic surgeons a lot to make sure that if we fix a fracture, that we have some way of closing the soft tissue over it, because otherwise, one, it's not going to heal, two, it's going to get infected. Now your hardware that you just put in is going to get infected. So now you have to take that out. Now this person has a chronic non-healing wound. So it becomes a nightmare if you don't address the soft tissues. What is, someone comes in with an open fracture. What is the most important thing to prevent infection? Antibiotics, right? So it's like, is it going to be like acuity to get to the OR? Is it whether or not you wash them out in the ER? Is it, you know, whether or not you fixed it with surgery or not? Or is it how quickly you got to surgery? It's antibiotics. Okay, you see that on a test, antibiotics, first number one thing. When you're a resident, if you're an intern, you're starting out, and someone comes in with open fracture, the first thing, antibiotics. Okay. Let's see. Right, we talked about extra-articular versus intra-articular. Extra-articular being outside of the joint, intra-articular being inside the joint. You want anatomic reduction is how we call it. You want to line the cartilage back up so you don't get chronic arthritis for time. And then nearby structures, you know, you got to know your anatomy, you got to know the vessels, the nerves, tendinous attachments, muscular attachments, because that all influences how you treat things, how things are going to act after you treat them. And then there's lots of cool things that you can do with them. You can manipulate them. You can do tendon transfers. If someone's born with like an Erb's palsy, you guys know what like an Erb's palsy is, like basically like if you're born and some traumatic event happens where you have damage to your brachial plexus, which I know you guys with like anatomy are traumatized by that, right? You guys can cite it right now, right? Like probably better than me. Like draw it out. I know you can do it, right? Yeah. So if you get like, you know, something like that, like most of those do fine over time with just observation, but like you do get the rare case where like their nerve function doesn't come back. So, you know, what are you worried about? If they stay contracted like this for a long time and they can't move it, you know, you can get chronic change to your glenoid, you can get bony changes that your body just stays like this and now it becomes a problem for the rest of their life. So you can do things like tendon transfers, you can take muscles and tendons that work and reroute them to do the functions that your out of function muscles can't do anymore. So pretty cool stuff. Yeah. Okay, so we'll just go through some examples. What is this? It is, yeah, that's the eponym for it. But who wants to read it as like the basics? Like, what are we looking at? What views, body part? Just start with the views. What in the body part? What are the views in the body part? Exactly. AP, oblique, and lateral of right hand. Yes, right hand. All right. Okay, cool. So are they skeletally mature or skeletally immature? You guys don't know because you haven't seen enough x-rays, but you will. This is a mature person. This is an adult. Okay. So who wants to describe the fracture? Well, first of all, does everyone make sure everyone sees the fracture, right? This is normal cortex, and this is cortex that's disrupted from here, right? So this, your wrist should kind of look like this, but now this is broken off. Does everybody see that? And this is kind of tilted this way. This is kind of hanging off instead of being up here.
Is this a Colles fracture?
Distal radial fracture that has dorsal displacement and angulation.
Yeah, pretty good. Yeah. So I would say that it's, you know, it's a fracture with distal radius, right? It's distal, right? It's the radius, right? It's the bone is the radius in your forearm. It's distal as opposed to proximal, as opposed to midshaft. And then it's on this view in particular, you can see that's angulated dorsally, right? Like you were saying. So this is dorsal, this is volar, it's angulated that way, and you can see that the whole hand and the whole wrist is kind of moving with it, right? So yeah, you could call that dorsal angulation. You could also, another way to say it, which is apex volar, which is like the apex of the angulation is apex volar. So if you ever hear that, that's what the same, it means the same thing. It's also a little bit short, which is kind of more advanced for like if you're like a third or fourth year medical student, like looking to start your orthopedic rotations. It's kind of helpful to start looking at radiographic parameters, right? Like there's certain angles and lengths that it should be in relation to this, and you should, you know, start to get into, but it's, you know, for later. There's a nerve that comes right here. It's a very important nerve. What are you worried about with this if you just leave it?
Oh, median nerve?
Yeah, what's that condition that?
Carpal tunnel.
Yeah, you can get a carpal tunnel if you have a severely dorsally angulated fracture. You know, it doesn't get reduced. So people will come in with this, and you have to ask them, like, do you have numbness or tingling or anything like that in these fingers? And you know, yeah, it's cool. So what would you do with this? Like, what do you do with this now? This person comes into the ER, and you're the orthopedist in the hospital. You're the only orthopedist in the hospital because everyone else is at home sleeping, and you're the junior resident. This comes in, like, what are you gonna do with this, right? Like, so what we do is, the first thing that we'll do is recognize that it's a fracture, and then we'll go over there and we'll do a hematoma block, which is basically you take some lidocaine and you inject it right in here, and you go straight into the fracture site, and you aspirate back to see some blood, and that tells you that you're in the fracture site directly. And you'll push like 20 cc's of lidocaine directly into it, and it's amazing. Like people who are like sitting there crying, all of a sudden, like you can flop their arm around and they're like, oh my God, I don't feel anything. Like, you're amazing. I'm like, yeah, well, yeah, no. But it is cool. Like you're acutely, like, now they have no pain. And then from there, you can actually reduce the fracture, which is basically like you want to put the bone back straight, right? So what we do for this is we actually, like, we'll take someone here, lay down. Yeah. Right. So what we'll basically do is, like, we'll lay them down like this, and if your wrist is fractured, right, like flopping around, and it's short, right? So we got to get traction and pull it back overward. So right now, pretend you're dorsally angulated. Yeah, good. So how am I gonna get this back over? Like, you could just kind of push it like this, but sometimes something we do sometimes, we'll actually put our leg over their arm, and we'll actually like tug up on it to get traction, and then put a thumb here, and we'll go up and over, and that should reduce it. Good job. All right. Yeah. You can, yeah, you can hang them. So like for really tough fractures that like you can't reduce like that. You can hang them. So you can either like tie the fingers and kind of hang it like this from an IV pole and put weights on the arm. You can get finger traps, which are like specifically like Chinese finger traps. Literally, that's what they are. And you just put them on your fingers and you hang them like this. And the idea is that the gravity and whatever weights you put on the arm will pull traction out long enough for the muscles to relax and the bones to kind of come out like this. I had to do that recently for like a really bad fracture that was, you know, had like a volar shear, right? So like no matter what you do, like gravity's the muscles are just gonna pull it back. It was not staying up. So I had to hang it and then put the splint on like that. Yeah. Any questions on that? So again, this is another wrist fracture. Who wants to try to read this one? What views, what body part? Start with that. Start with the M1s now. Maybe the M1s. What views and what body part? Same, I'll give you a hint. It's the same views as the last one. So there's an AP straight on. This one's like this. It's oblique. Lateral. Yeah. So AP, oblique, and lateral of the left wrist. Good. So what do you see wrong with this one? Is there a fracture? Okay. Yeah, yeah, something's wrong, right?
Not right.
Yeah, it's not right. That's it, yeah. Exactly, it's not right. This is, yeah, again, it's a distal radius fracture, right? So again, this is the radius, is the distal part of the radius, and this is hanging off, right? Does everyone see the outline there? Again, here, it should be up here instead it's down here. What about this view? How is this different than the last? What's the angulation like to you? Yeah, it's volar. It's going the other way. It's going this way, right? So the last one, look at the lateral view. Right? So this is the right wrist and it's going backwards. Oops. Now this one is the left wrist and it's going forwards.
You do that.
You fall this way. You fall into the back of your wrist. Yeah. Somewhat uncoordinated. I don't know. Yeah, these are a lot rarer for that reason. Like most people, do this, but you can see them. They do happen. They're a lot rarer.
Is it just forward space or is it lateral?
Yeah, yeah, it's a little bit. So you could say like this is radial, this is ulnar, right? So this is like radially translated too. Yep. Right. And it's also very shortened, right? And it's normally up here. Now it's down here. So that's going to cause problems if you don't treat that. So recognizing that if you're going to reduce this, you can't do what I did to this guy, right? Where I push on the back side and flip it over, right? So I have to do it the other way. I have to push on the front side and flip it back over that way. Okay. Okay. What's going on here?
Good question.
Yeah.
I was just wondering, like, why is the nomenclature, like, why is it volar, not ventral? Like, usually I feel like we hear dorsal and ventral. And...
That is way above my pay grade. I don't know. Someone a long time ago said that's going to be the nomenclature, and now I just have to deal with it. Yeah. All right. So this is, who wants to try? It's the same views as last time. Yeah, AP, oblique, and lateral, left wrist, exactly. I intentionally made them all very similar so that you guys could learn. So I'm not trying to trick you guys, I promise.
Skeletally immature.
Yeah, what makes you say that?
The finger bones.
The finger bones. The finger bones. Yeah. Good. Right. So what are these all little fractures? Like he fractured every bone in his body? Like no, probably not, unless you have like osteogenesis imperfecta, which can't happen. But this is a skeletally immature kid. This is a growth plate, right? This is a growth plate. These are growth plates. And actually, when we're talking about let's say like a kid, their age may not match their bone age. So sometimes they were saying, okay, this kid has scoliosis, they're gonna keep growing or they're gonna stop growing. And we decide how we manage scoliosis very much based on how much growth they have left, right? So if I just say I'm 14, well, it doesn't necessarily tell me a lot. So how do you tell their bone age? We take an x-ray of their hand and you can tell what their bone age is based on what their physes look like, their growth plates. So that's kind of important. So this is a kid. And he has, well, what do you guys think he has? What's wrong? Okay, yeah. So the radius and the ulna are both fractured, right? We actually call that a very fancy term. It's called a both bone forearm fracture. Right? How would you describe like the fracture pattern? Transverse, oblique, spiral, comminuted. Yeah, it's pretty transverse, right? How about the angulation? Good, yes. Definitely not great.
Dorsal and ulnar.
Yeah, exactly. So it's dorsally angulated or apex volar, and it's ulnarly kind of deep, like ulnarly angulated, right? Good. So when you reduce this, you're gonna kind of push on the back side again, flip it back over, and then I would put a hand on the ulnar side and kind of straighten it out that way. And these actually do great. Like you don't have to, like, you reduce it, you put in the splint, you send them home, and they heal amazingly. Like in a year, like they'll never know that they fractured. It's pretty cool. It looks really bad, but like we see these all the time. And this is what it looks like after a reduction. After a closed reduction, you put in a splint. All right. And he's gonna do great. So usually we'll do a splint just to hold the bones in place for like 2 weeks. And then a lot of parents will ask like, oh, why don't you just put in a cast right now? Because you have to leave room for swelling, because in the acute phase, you're gonna have a lot of swelling that is most maximal in like the first week or two. So if you put a cast on, it's like more rigid and circumferential, you can get compartment syndrome. Do you guys know what compartment syndrome is? So basically you get a lot of swelling that can't get out, and now they have a really big problem. Whereas if you put a splint on acutely, you can mold it and it gets hard and it's somewhat rigid, but it's only like on this side and this side. So there's room to expand. And then we'll see them in the office in like 1 or 2 weeks, depending on how likely they are to displace. I think like, oh, this guy's gonna do fine. I'll see him in 2 weeks. And we'll see him in the office. We'll take the splint down and then we'll put him in a cast. And then he'll be in the splint for 2 weeks and the cast for like another 2 to 3 weeks. It'll be good.
I'm noticing some like residual displacement of the ulna in this X-ray. Does that correct over time with bone remodeling?
Yeah, exactly. Remodeling. So in a kid, right, like there's a tiny, it's not like absolutely perfect. In a kid this age, like there's acceptable criteria you have to know. There's certain degrees of displacement angulation that you have to know that are acceptable for like every type of fracture. Like every fracture has its acceptable criteria that will go on to heal. So, when you're studying for your ortho rotations, and that's something you should kind of know is like, what are the acceptable criteria for this and does it fit? In this situation, like it's more than acceptable. He's going to do great. Over time, you're going to get some callus forming over here, and then it's going to remodel because he still has time to grow, and it's going to look perfectly normal.
So when you reduce the fracture, do you have to worry about the rotational alignment of the top and the
Definitely, yeah. I mean, this one was pretty easy because it was not really rotationally off. Like the cortex in the back was still intact here. It was kind of hinged, so you kind of just push it over and it finds its way back. But like you get like some really badly displaced ones where it's like rotated and displaced, and those are way harder to get reduced. So if you line it up and get the get it right on the AP and the coronal plane, the sagittal plane, the AP and the lateral basically. But it's still not clicking in. Like sometimes the rotation is the issue, so you have to rotate and see, trying to click in that way. Yeah, but rotation is very important.
So I have a question.
Yeah.
Explain to me how like certain wrist fractures will relate to like the elbow,
How wrist fractures.
and like say like some fractures will result in like a cast with the elbow without.
Oh yeah, that's a good question. So like a short arm cast versus a long arm cast,
Yeah.
basically.
Yeah.
So it depends on the fracture pattern and where it is. Basically, if you want to control for rotation, right, your radius and your ulna, the point of them around each other is that you can pronate and supinate, right? So if you have a fracture where you're worried about rotation, making the fracture unstable, and if you only cast up to here, they can still do this, right? But if you don't want them to rotate, you have to go up to the elbow. So if you include the elbow, you take out rotation. All right. Same thing with the tibia and a cast, right? Like if you want to control rotation, you have to go up past the knee. But if you're fine with no rotation, then you can stay below the knee. Okay. All right. What do we have here? Femur. Yep. Yep. Yep.
What is that little white piece?
Little piece of bone. Yeah, little piece of bone right there.
Technically called you, but like I'm so small that I don't.
Yeah, like you.
actually
Yeah.
Be how you would call that.
Yeah. Yeah. So what do you think? What is this view of the? Yeah, good. And what do you see on here? Using your adjectives that you learned today. How are the bones in relation to each other? Short. Yeah, it's pretty short, right? Because what happens when you break your long bone, your muscles contract, right? So now your femur is, instead of like this, is like this, right? That's no bueno. That's painful. Okay, it's short.
Does that count as bayoneting?
Yeah, same thing. Like shortening and bayoneting, basically like is like when they're kind of like laying on top of it. Yeah. What about this one? What is this? No, it's an AP of the femur, but just more distal. Yeah, yeah. And then how would you describe the fracture, if you could? Let's talk about angulation there. So in the legs, we usually say varus or valgus.
It's basically distal portions, right?
Yeah, so it's a little bit of varus, right? And then what about this one? What view is this? Lateral view of the femur, right? Distal femur. And what's up with the angulation here? Yeah, it's like, yeah. But it's pretty angulated, it's short. This is not a fracture that's going to heal on its own if you leave it. So what do we do acutely? We'll provide traction. This is a traction pin. Basically, we just give them a little lidocaine injection and we shoot a pin across their tibia, and then we hang some weights on it, and it pulls the femur out to length. And we do this like very regularly in the ER. Well, this we actually stopped doing so much. Now we do what's called bucks traction, where we put them in a big Velcro boot and hang the weights off the boot, which is a lot more like, I would want that if it were me. I wouldn't want someone shooting a pin through my tibia if it didn't need to happen. There's been papers that came out showing that they're equivalent, I guess.
Doing something where you're driving pin direct.
Yeah, it's more of a concern. Like pin site infections like aren't that common, but like if they stay like that for a while and you don't take care of it, like it's definitely something to consider. So like if you had to choose between that or bucks traction, and where you're just putting a boot on, like, you know, that's an advantage of bucks traction. But if you're somebody who's going to be like, let's say you're in the ICU, or a bad motorcycle accident, you have a brain bleed, you have a liver laceration, you have femur fracture, we can't take you to go to the OR, fix your femur fracture until all this stuff's taken care of. So it's say you're going to be in the ICU for a while, we can't just leave your femur like this. So put them in skeletal traction, which is what this is called, until we can fix their bones. All right. And that's a traction pin, right? So you're like in the ER, like shooting your, you know, with your pin, and you're shooting it across, and you get your X-ray, and that's the pin going directly across. And that's what the bone looks like with traction. And then you take them to the OR the next day to do an intramedullary rod. This is just here. We don't have to go into this. Fracture healing phases. You get callus. You'll study this. And then basically, you know, there's like AO principles of fracture fixation. So when someone comes with a fracture, first thing you do is reduce it. You worry about length, alignment, and rotation again, like I discussed. You put it in a splint, you put it in a cast, put it in traction, whatever you have to do, reduce the fracture so it's not sitting there wrong. Then you have to stabilize it. That's where your surgery comes in. There's different types of stabilization, which is, you know, we can save for another lecture. It's a whole topic on its own, but basically you have absolute fixation versus relative stability. That's how you're gonna, so if you get your bone reduced, well, how you're gonna hold it reduced, and that's where the surgery comes in. You stabilize it with a plate or a rod or whatever. And then you have your blood supply. Make sure you have good soft tissue coverage, right? Like you have to think about that when you're making your incision. Just recently, we had a kid who had a bunch of fracture blisters all over their ankle. We were gonna plans to make an incision here and fix the fracture like we normally would, but because he has all these fracture blisters, we're worried about wound healing and infection. So we had to change our plan and do things differently with less of an incision. And then if you have an open fracture, you got to get antibiotics, got to get plastics, got to get vascular. Make, you know, that's all very, very important. And then another thing that's often overlooked is mobilization. Like you have to make sure that they're up and going. A lot of times you have like these old people with hip fractures, and you know, if you have a hip fracture, there's like a 30% chance that you're gonna die in the next year after the older the age of like 65. That's like a statistic that's been studied. And what causes that, right? Like it's not the hip fracture, it's the fact that they're not moving and they're gonna sit on their butt and they're gonna get infections, they can get pneumonia, you can get venous stasis ulcers that can get infected, you can get a lot of things that can go wrong if you don't move. And a lot of orthopedics is about getting people up and moving in a safe way that doesn't disrupt the fracture, but up and functional so that they don't get all these complications that can occur. So yeah, it's like the whole picture. It's not just the fixing, but it's the whole thing all the way through. I think that's all I have. Yeah. Cool. Any questions about anything? I threw a lot at you guys, but it's 8 o'clock actually, so if you have to run, like, run, but I can stick around for those guys have questions. Anything I want to talk about? Yeah.
So when it comes to like plates and rods, and screws, are there like certain standards, or is it like case?
There's certain standards. There's like guidelines and there's principles that you have to follow. So I guess that's a whole other lecture we could talk about. But for the most part, if you like, relative stability is basically where you don't have the bone perfectly anatomically aligned and you have a little bit of motion. That's what you kind of do for like your tibia nail, your femur nail, as opposed to like your intra-articular distal radius. You want it to be perfect, right? So that you'd rather plate, right? So principles like that, but there are a lot of principles involved in choosing how you're gonna fix it. Yeah. Yep.
And that weak fracture, that small third piece, how big is the third section to be?
I mean, there's not like a specific size that says like this, it has to be this big to be called comminuted. You kind of look at it and you're just like, okay, does that matter? I'm sure like you could find someone somewhere who has defined the size of that size, but like we don't really do it that way. Yeah.
It's also proportionate to like the long bone versus like the same size piece of bone. Your scapula is gonna be a lot different than other people.
Yeah. Like for example, like in like your capitellum, for example, which is like the little part of your elbow, you can accept like 2 millimeters of displacement until you have to fix it, as opposed to like your like both bone forearm in a kid, where you can accept up to like a centimeter of bayoneting. Wow. Yeah. So depends on the bone and where it is. Yep. And a kid under 10, if it's like this, like a centimeter, you leave it, you're gonna do fine.
That's pronation and supination.
Nope, it won't. It'll remodel. Yeah, our pizza attendings have like a whole like PowerPoint of like, will it remodel? They never gave it. Actually, I'm like, I want them to give it to us because I haven't seen it yet, but they have like they've showed me like, oh, like I have all these fractures, like look at this, like do you think it's gonna remodel? And I'm like, hell no, like that looks horrible. And then I see them like come to office and they're like running down the hallway. I'm like, holy shit, like, that's pretty, like, so it's pretty, yeah.
So you're talking about like bone age for like pediatric patients. Does that also work on like the opposite end of the spectrum for like older adults, like these some 9-year-olds? Like I'm sure some 9-year-olds are like better candidates for surgery than like 7-year-olds. So does that like bone age hold true then, or is it like a different thing you're looking at?
It's good question. It's not so much bone age. Like bone age, you look at the growth plate. That can kind of tell you like how old their bone is. As you get older, it's not so much about like the age of their bone as like the quality of their bones. Like, are they osteopenic or osteoporotic? If you have like weak bone that like is not going to withstand you drilling through it and putting screws through it, like you're going to treat that differently than if you have like strong young bone with like a thick cortex that you can put screws in and you're worried they're not going to cut out. So it's like, imagine like you're drilling through a piece of wood, right? Like if you have like a soggy piece of wood that's like 90 years old, like you drill through it, like it's not going to give you as good capture. But if you have like young hard wood that like you can hammer nails through, like you might treat that differently. And you could when you're doing a hip replacement, some people use cement versus no cement. We look at the quality of the bone on the x-ray to see like how we're going to fix that. Yeah.
When do fractures become concerning for the girls?
That's a whole topic. Um, different growth plates grow at different rates, which is something that you learn like as a resident. Like you have to know, like, okay, this like the distal femur, that growth plate grows at 9 millimeters per year, and as opposed to like, you know, your proximal tibia, which grows at 6. So it depends on how old they are and what that physis is, what kind of fracture through that physis was. You know, if you have a fracture through your physis, like the number of times you try to reduce it actually can impact their rate of growth the rest. So there's a lot of factors. There's a whole classification based on like the fracture pattern through the physis called the Salter-Harris classification. I think we learned about that in med school. I don't know if you guys are doing that yet, but it's
Straight across then.
yeah, it's like different patterns of how it goes through the growth plate. And like that's, you know, all considerations into whether or not they're gonna go into like a complication. Any like general questions? No. I hope that was cool. I'm like a giant nerd about this stuff. Thank you. Yeah, no problem. Yeah. I don't know if I have to.
Thank you very much.
Yeah, no problem.
Thank you.
Yeah.